Professor Beda,
Hi, Ahmed. How
how
are
are
you?
you? I think it's good. I'm fine.
Mm, I'm fine.
It's pleasure to see you always.
Thank you, Ahmed. So,
So you
Dr.
told
Goel
me
is
that.
traveling. He's at the airport. I don't think if he can, he will join in between, but we'll continue. Okay?
Okay, that will
Yeah.
be good. So we have 5 minutes to start. If you
Yes.
like to test screen sharing, we can do it now.
Okay.
Okay,
Okay.
perfect. Okay, that's perfect. Great.
Okay.
Dr. Abeda, I think we can start now. I will do welcoming for the audience and introduce you, then you can start, okay? Is that good?
Yeah.
Okay, so welcome everyone to the 15th webinar of the Comprehensive Neurosurgical Anatomy course that organized by the Many Neurosurgical Society in collaboration with World Federation of Neurosurgery, Young Neurosurgery Forum, and Neurosurgery Coach, Pakistan Society of Neurosurgeons, and Neurosurgical TV. Today, we have a Professor, Dr. Ubaid Shah, Professor of Neurosurgery at SIF JS Medical College and King Edward Memorial Hospital in Mumbai. She will talk today about surgical corridors to the brainstem safe entry zones. Dr. Ubaid Shah, thank you for your contributing with us and for your continuous support to our programs.
Thank you, Ahmed. And you can see my screen?
Yes, that's great.
Okay, so it's my pleasure to be here, as in all your webinars over the years. So today, let us talk about the brainstem. So as we all know, the brainstem is a very intricate structure with very, very complex anatomy. And it is very essential to know this anatomy when you're performing surgery for intrinsic brainstem tumors, and also to know what exactly the brainstem is made up of. So if you look at it anatomically, the brainstem is made up of gray matter and white matter. The gray matter are two types. One are the cranial nerve nuclei that we all know, and one are native brainstem nuclei, which are gray matter masses within the brainstem itself. And the white matter, we just look at it at white matter going to and through the brainstem. Let's look at it a little differently. So I would say they are short and long projection fibers, in that they connect brainstem to different parts of the cerebral hemispheres and to the cerebellum. Traversing fibers are those which go through the brainstem without synapsing in the brainstem. Association fibers connect various parts of the brainstem nuclei to each other. And then there are commissural fibers, or the various decussations in the brainstem. So to understand surgical corridors to the brainstem or safe entry zones to the brainstem, it is very vital to understand this anatomy and then plan your approach through the brainstem. So what I have done is, in the paper that I just showed you, we've divided the brainstem into 3 zones. So zone 1 comprises of short projection fibers, zone 2 comprises of traversing fibers and long association fibers, and zone 3 comprises of association fibers and decussations. So if you look at this, this is the cut section at various levels in the brainstem. So this most lateral part, the blue circle that you see, is zone 1. This yellow circle that you see is zone 2. And the third one, the green one, is zone 3. So they are all like cylinders. The outermost cylinder is zone 1, the inner one, the second one is zone 2, and the innermost one is zone 3. And they occupy all around parts of all around the brainstem. So if you look at the sagittal and coronal sections, so this will be zone 1, this is zone 2, and this is zone 3. Similarly, in the ventral aspect. So now what are the fibers that comprise these zones? So zone 1 are short projection fibers, and these are fibers connecting the brainstem to adjacent geniculate bodies and the cerebellum. So which are these fibers? The superior, middle, and inferior cerebellar peduncles, the superior and inferior brachium, and the lateral lemniscus. I will show you all these fibers as we see the images later on, but this is just to give you an overview. So zone 1 is the outermost zone, and it is generally the safest zone to enter the brainstem. So if you look at this image from the dorsal aspect of the brainstem, this will be your short projection fiber. So this is the superior brachium, this is the inferior brachium, this is the superior cerebellar peduncle. So again, you have the superior and inferior brachium. So that is the superior and inferior colliculi being connected to the thalamus, the superior cerebellar peduncle, which is connecting the cerebellum to the midbrain, then the middle cerebellar peduncle, which is connecting the pons to the cerebellum, and the inferior peduncle, which is connecting the medulla to the peduncle, to the cerebellum. So this is the zone 1, or the outermost aspect of the brainstem. And as you can see, it is relatively safe to venture into the brainstem through these avenues. If you look at it from the ventral aspect, you know that your safest entry to enter into the pons is in the region of the peritrigeminal area. So this is the region of the middle cerebellar peduncle. Now, what is zone 2? Zone 2 consists of traversing and long projection fibers. So the traversing fibers are fibers that just traverse through the brainstem without synapsing in the brainstem. That is the corticospinal tract, the spinal lemniscus, the dorsal and ventral spinocerebellar tracts. And long projection fibers are those that connect the synapse at some gray matter level in the brainstem and then go on to the supratentorial portion of the cerebral hemispheres. So this is the medial and trigeminal lemnisci, the corticobulbar, corticopontine fibers, the reticulospinal, rubrospinal, and vestibulospinal tracts. So if you look at this cut sagittal image of the brainstem, this is the corticospinal tract. This is the medial lemniscus. This is the region of the medial longitudinal fasciculus and the central tegmental tract. This is, of course, zone 1. This is the region of the superior cerebellar peduncle. And if you look from the ventral aspects, this is zone 2. So entry into the zone 2. So again, on the floor of the fourth ventricle, this is zone 2. So entry into zone 2 is through specific designated areas. You just cannot enter the brainstem through any portion of zone 2, which is unlike in zone 1, which majority of the times you can enter into it. In zone 2, you have to go through specific areas that are called safe entry zones into the brainstem. So this is the region of the inferior cerebellar peduncle. Zone 3 are the last ones, are the association fibers that connect various parts of the brainstem nuclei to each other. So the medial longitudinal fasciculus, the tectobulbar tract, and the central tegmental tract. Now this is a complete no entry to enter into the brainstem. So all these tracts lie in the middle of the brainstem, and this is a complete no entry zone to enter into the brainstem. So zone 1 is basically safe. Zone 2 is entry through designated safe areas, and zone 3 is basically a no entry. So now let's look at the anatomy of the brainstem, and I will show you some clinical cases along the way to see how we decide about the approaches to the brainstem. So this is the Greek god Atlas, and you can see that he's holding the universe on his shoulders. Similarly, the brainstem with the cerebral peduncles holds the cerebral hemispheres by its two arms, and it simulates the Greek god Atlas by doing this. So you can see this is a DTI image superimposed on the anatomical image, and this is how the cerebral peduncle holds up the cerebral hemispheres. So the brainstem can be divided into a ventral part and a dorsal part. So let's look at the midbrain first. So the ventral part of the midbrain comprises of the ventral crus cerebri, the tegmentum, and the tectum. So the ventral portion of the midbrain is comprised of the crus cerebri, and this portion that comprises of the substantia nigra and the red nucleus, that is the tegmentum, and the plane that obliquely goes between crosses the aqueduct is behind that plane is the tectal plate or the tectum. So these are the way we look at the anatomy of the midbrain. Now let's start dissecting the brainstem from anteriorly, from laterally, and posteriorly. So let's start with the midbrain. So here you can see the cerebral hemispheres. So when you're looking from the anterior aspect, if you normally cannot see the crus cerebri, you have to lift the uncus. So you see this region, this is the region of the uncus and the parahippocampal gyrus. So the cerebral peduncles are hidden within this region. And when you separate this, you'll be able to see the cerebral peduncles. Now the midbrain extends from this line, the optic tracts, all the way here to the pontomesencephalic junction. So it is actually a line that is connecting the mammillary bodies to the posterior commissure in an axial plane. And the region between these two structures is the midbrain. So the midbrain ventrally, as you know, is comprised of the crus cerebri. This is the interpeduncular fossa. It has the posterior perforated substance through which various branches of the basilar artery, perforators, enter into the brainstem to supply it. On the medial aspect of the brainstem, you have this sulcus, the oculomotor sulcus, from which the third nerve arises. On the superior aspect, you see this is the mammillary bodies. This is actually the pituitary stalk. This is the optic nerves, chiasm, and the optic tract as it is going around the brainstem. Now, dissecting the fibers in this region, you will see that when you remove the first layer of the crus cerebri, you will see these fibers. So the crus cerebri, or the cerebral peduncle, is made up of three sets of fibers. So you can divide it into three parts. So the medial 1/5 is composed of the frontopontine fibers or the Arnold's fasciculus. So it connects the frontal lobe to the pontine nuclei. The middle 3/5 of the crus cerebri is made up of the corticospinal tract, and the lateral 1/5 of the cerebral peduncle is made up of temporopontine fibers that connect the temporal lobe to the pontine nuclei. It is also known as Turk's fasciculus. In between this region, you have this ganglion here, that is the interpeduncular ganglion, and it goes on to make up the floor of the third ventricle. Once you remove the first fiber bundle in this region of the crus cerebri, you see a pigmented structure here, that is the substantia nigra. So the substantia nigra extends all the way up from the cerebral peduncle to the subthalamic region, and it forms a layer going all the way medially from the oculomotor sulcus all the way laterally to the lateral 1/5 of the cerebral peduncle. So once you remove these fiber bundles, so I've removed this fiber bundle, I've removed the substantia nigra, and you see this gray matter mass. So this is a gray matter mass that is native to the brainstem, and this is the red nucleus. So again, you see this structure here is the interpeduncular ganglion. This is the region of the third ventricle. Here you see the mammillary bodies. These are the fornices. Here you can see the corticospinal tract, and more laterally you see the temporopontine fibers. Here the optic tract has been cut to see how these fibers enter from the cerebral hemisphere into the cerebral peduncle. If you note, this oculomotor nerve arises on the medial aspect of the red nucleus and traverses the part of the brainstem before coming out. So this is on both the sides. You can see the red nuclei on both the sides. You can see the oculomotor nerve as they come, and you can see the cerebral peduncle as they're continuing down into the pons. So this is the continuation of the cerebral of the corticospinal tract into the pons, as you can see in this image. So now this is just an overview of showing all the fibers of the brainstem and how they are going down from the ventral aspect into the pons. So when you look at it from laterally, so the lateral aspect of the midbrain is made up of the lateral 1/5 of the cerebral peduncle, and this structure here, that is the lemniscal triangle. Now, what is this lemniscal triangle? There is one sulcus that runs on the lateral aspect of the midbrain, that is the lateral mesencephalic sulcus. So the area that is posterior to this lateral mesencephalic sulcus and bounded superiorly by the inferior brachium and inferiorly by the superior cerebral peduncle, this is the lemniscal triangle. And why is this important? Is it because it is generally considered safe to enter the midbrain from this region. More posteriorly as you go, you see this is the dorsal aspect of the midbrain, or the tectum or the tectal plate. So here you have first you can see that the pineal body rests in this region. There is a depression where the superior colliculi meet on the posterior aspect of the brainstem, and the pineal body rests in this region. This is the superior and this is the inferior colliculi separated by this cruciate sulcus. If you see the fiber bundles here, you can see that there are some fibers that are coming here from the superior colliculus and going all the way to the lateral geniculate body. These are fibers coming from the inferior colliculus and going to the medial geniculate body. This structure that you see coming down is the frenulum villi. And just beneath that, you will see this thin structure that is going from the posterior aspect of the brainstem all the way anteriorly. And that is the fourth cranial nerve, or the trochlear nerve. So this is the only cranial nerve that arises dorsally on the dorsal aspect of the brainstem. All the other cranial nerves arise ventrally. It is also important to know that the midbrain carries a part of the course of the third and the fourth nerve through its structure. So the third nerve, as you saw, it traverses the medial aspect of the red nucleus and comes out. Even the fourth nerve comes from the lateral aspect of the aqueduct, comes on the posterior aspect, and then turns and comes out and traverses to go near the tentorial free edge. So here this is the tectal plate. Here inferiorly you will see this is the superior cerebellar peduncle, and it is connecting the midbrain to the cerebellum, and these comprise mainly of efferent fibers that connect the midbrain to the dentate nucleus. And in between you see this structure, that is the superior medullary vellum, or the roof of the fourth ventricle, which we will see later. So now coming to the safe entry zones of the midbrain. So ventrally, because there is this huge fiber bundle of the corticospinal tracts and other important tracts, it is virtually difficult to enter the brainstem from anteriorly. However, this safe entry zone has been described just lateral to the oculomotor nerve, where you can enter into the ventral aspect of the brainstem. So this is the region where you will enter when you're coming from ventrally, but there is the basilar artery and there are so many perforators, so it is a very technically demanding approach. The next safe entry zone to the midbrain is this region, that is the lemniscal triangle that is present on the lateral aspect of the midbrain, as I discussed earlier. So this is the second safe entry zone. So this, when you have a tumor that is arising in the lateral part of the brainstem, this is how you will enter. You will go into this region. Here you can see the bulge of the midbrain and how it is shining. And this is the region of the glioma. Again, another ventral tumor in the cerebral peduncle and also affecting part of the tegmentum. And you can enter from this aspect in the region of the lemniscal triangle and remove these tumors. Now, while we were doing our dissection studies, we realized that there is a better approach to ventrally placed intraaxial midbrain tumors. So you don't need to come from ventrally when there is a corridor that is present laterally. So as I showed you, this is the cross section of the midbrain. So this is the region of the frontopontine fibers. This is the region of the temporopontine fibers. This is the region of the aqueduct. So the safe entry zones have been described coming through this region and sometimes coming from posterior to the colliculus. Now, just to show you, this is the region of the red nucleus. This is the region of the substantia nigra. This is the region of the middle lemniscus. This is the region of the medial longitudinal fasciculus. Now, if you divide, as I showed, you can divide the cerebral peduncle into three parts. So as these frontopontine fibers are little easy to go through, similarly, there is an avenue through these temporopontine fibers that you work between these fibers and the substantia nigra in this region, and you can enter and approach ventrally placed midline tumors in the midbrain. So when you know there is a tumor, the tumor has actually expanded the brainstem. So there is no definite anatomically zone that you will be able to identify when you're operating, but you have to know the anatomical landmarks and try to approach the lesion from its most prominent aspect. So this is the trajectory. So this is the lateral aspect of the lateral 1/5 of the cerebral peduncle, and this is how you will enter it. The way to do is it by going retrosigmoid and using a lateral supracerebellar approach. So here you see the 5th cranial nerve, the 7th, 8th cranial nerve complex. Here you can see the 4th cranial nerve as it is entering the tentorial region. So you depress the cerebellum, you expose this area. You might have to cut the cut tent to reach this region in the brainstem. And here you see the tectal plate. And this is the region. This is where you will enter and approach the tumor like this in a medial and a sagittal direction. And you will get the ventrally placed tumor above the 4th cranial nerve. So this is the trajectory and this is your way you will enter. So this is the tumor. Now you can see that there is a large cyst posteriorly, but there is a solid portion of the tumor anteriorly. So coming anteriorly would have been very difficult for this tumor. And that is when we used our knowledge of anatomy to describe this avenue to enter into this region and remove this tumor. This turned out to be an oculomotor nerve schwannoma arising from the intramesencephalic part of the oculomotor nerve. And I will just show you a part of a short video. So here you can see that the cerebellum has been depressed. You see the 4th cranial nerve here. You can see it. This is the thin 4th cranial nerve that is running. This is the region of the tent. Now, as I showed you, I want to go more superiorly. Here, we are actually also seeing the anterior aspect of the brainstem. So there was a suspicion whether some part of the tumor is projecting outside, but it was completely intraaxial. And we looked into this trajectory and saw that there was nothing projective outside. This is how the tent is cut. So this is the tentorial cut. You can safeguard the 4th nerve completely by separating it from the free edge. And here you can see that the 4th nerve is free here. The 10th is completely free from the 4th nerve. And this is the cutting of the tentorial edge. And now you can see that the whole lateral aspect of the midbrain is exposed. And now this is the entry point above the 4th nerve, splitting the fibers of the tectopontine fibers, and we have straight entered the cyst. And then the solid portion of the tumor that you can see here. and then you dissect within this region. And actually we could remove this whole tumor in a form of a whole nodule. And here you can see that the tumor has come out. And you can see it has the typical consistency of a appearance and consistency of a schwannoma. And then we just replace the tentorial flaps back. And this is at the end of the surgery. There you can see this is the trajectory, and this is the entry point for this tumor. So here the tentorial flap is being replaced, and that is the end of the surgery. So that the patient did very well. She did develop a third nerve, but that was because the tumor was arising from the third nerve. This again another tumor in the tegmental region of the midbrain. Again, we approached using a similar trajectory. You can see that in this image, and then you can see that the whole tumor has been removed. Now the same trajectory, if you don't want to go supracerebellar infratentorial, you can go from the subtemporal avenue. So you can lift the temporal lobe and then use the same approach. So you can see this is a view from the subtemporal region. Here you can see the fourth nerve that it is as it is running and entering into the tentorial edge. You can see the PCA and the superior cerebellar arteries. This is the third nerve. And so this is the region where you can enter and make your make your incision and enter into the midbrain. So this is a lesion again in the lateral aspect. And you can see this is the direction of our approach. You can see the trajectory here, and you can see that the tumor has been completely resected. So this is in the ventral and lateral aspect of the midbrain. What about if the tumor is in the dorsal aspect of the midbrain? Generally, tectal plate gliomas, you don't need to operate. If they're compressing the aqueduct and there is hydrocephalus, you just need a shunt. But if you have to operate on a tumor in this region, this is the way to go. So this is a midline suboccipital approach with a supracerebellar trajectory. And this is how you will depress the cerebellum and reach this region of the tectal plate. So when you want to enter the dorsal midbrain, there are two safe entry zones that have been described. And as I said, they are through the zone 1. So this is through the superior brachium and through the inferior brachium. This is the supracollicular area, and this is the infracollicular area just above the fourth nerve. And they are relatively safe areas where you can make an incision into the brainstem. So as I said earlier, this is the avenue. So this is the suboccipital craniotomy, and this is the supracerebellar root. And this is the exposure that you will get of the tectal plate and the superior medullary velum and the superior cerebellar peduncles. So this is a tumor that I did recently right in the tectal plate. So this was quite a huge tumor and had to be excised. And you can see I've used this trajectory and removed the whole tumor. And this is the most danger to this region is the problem with the eye movements. And here you can see that the eye movements are completely normal. This turned out to be a pilocytic astrocytoma, and the patient is doing well. It is now 1.5 years after the surgery, and he's on regular follow-up. This is again another lesion another important different vascular tumor that I operated through this same approach. This is an AVM of the tectal plate. And here you can see that we use 3D models to actually identify the arterial and the venous phase so that we could define the AVM and remove it. And this was also successfully done. I'll just show you a few snippets. So this is the midline suboccipital avenue. Here you can see the supracerebellar approach. This is the arachnoid being lifted. You can see bilaterally the AVM is being supplied by branches of the superior cerebellar artery, and that is what I'm trying to do here first. Expose the area on both the sides by separating the arachnoid. You can see the arteries as they are going on to supply the AVM. I'll just go fast. So now this is the whole AVM exposed. You can see on both sides, the superior cerebellar artery is supplying it. This is an ICG view. So similarly, from both sides, the arteries were supplying, and this is the venous drainage. One was going into the tent, and one was going into the deep galenic venous system. And here you can see that the whole AVM is exposed in the region of the midbrain. So you see bilaterally how they're symmetrical vessels as they're entering into the into the AVM. And then I started resecting, and you can see that identifying each of these vessels as they enter into the AVM and coagulating them and cutting them. I will just go fast, otherwise we will not finish. dissecting coming all through. See, it is very, you cannot remove this AVM as it is stuck to the midbrain. So what we did is an occlusion of the whole AVM surrounding and, disconnecting it from all the vessels, and they're just leaving it on the top of the brainstem. This is the vein as it is entering into the galenic system. So each and every vessel was identified and then being coagulated and cut. This is nearly at the end of the surgery. This is the tectal plate that you can see here. This is the last part. There are still some vessels that are running from the vermis towards the AVM, which you can see. This is the vein that is going up and which has now been coagulated. And this is at the end of the surgery where you just see that little blob that is left on the brainstem. And then the whole AVM has been disconnected from the circulation. So this is again a tectal plate AVM, which can be approached surgically. Giving radiosurgery to this AVM would be difficult because of its close proximity to the brainstem. So this is how you can approach the dorsal aspect of the brainstem. Before going to the pons, there are some lesions which occupy the thalamo-peduncular region. So they involve the thalamus and the cerebral peduncles, and generally they are cavernomas. So these are also to be considered as brainstem tumors or thalamic tumors. And there are two ways to approach this that we generally use. So this tumor was operated from a posterior supracerebellar avenue. You can see this is the trajectory that we used. And the most majority of the cavernoma was removed. Here you can see the cavity, maybe just a small bit was left behind in the anterior aspect, but this patient is on follow-up and he's doing very well. And this is the DTI image showing the fibers. This is another cavernoma that I did recently. And you can see it is occupying the thalamus and entering into the cerebral peduncle in this region. And for this tumor, for this lesion, I used a posterior interhemispheric trajectory. And you can see the post-operative MRI, the whole cavernoma has been excised. And this is the trajectory that I used. So these are cavernomas that occupy and involve both the thalamus and the midbrain. And you have to know the anatomy of this region to expose it and reach the cavernoma. Now coming down to the pons. So what does the term pons signifies? Pons is a bridge. So basically it connects the cerebellum to the brainstem. It is a bridge from the cerebellum to the brainstem. So again, it has two parts, a ventral part and a dorsal part. The ventral part of the pons has this very notable structure that is the basilar sulcus, which hosts the basilar artery as it runs in this area. This portion of the pons is it is prominent, and it is made prominent because of the presence of the corticospinal tract. The part lateral to the trigeminal nerve as it comes out here is the middle cerebellar peduncle, and this part is part of the brainstem or the pons. So let's dissect the pons from anteriorly. So once you remove this first layer of the pons, you start seeing fibers running transversely, and then in the depth, you will see them running longitudinally. So what happens is when the corticospinal tract comes down from the midbrain, it is a longitudinal tract that is coming down, and it then gets separated by transversely running fibers that form three layers and separating the corticospinal tracts. So the first layer is stratum superficial. It connects these transverse fibers in front of the cortical spinal tract. Then you have the stratum complexum, which consists of transverse fibers running between the corticospinal tracts. And, so you have some transverse fibers and some longitudinal fibers. And in the depth, you have the stratum complexum. That is the last layer, which consists of transverse running fibers that connect the pontine nuclei to the cerebellum through the middle cerebellar peduncle. So you see how these transverse running fibers are joining and going laterally and entering into the middle cerebellar peduncle and running to the region of the pons. So this whole structure, ventral aspect of the pons, consists of these transverse, so pontocerebellar fibers, corticospinal fibers, corticopontine, and corticonuclear fibers. So the corticonuclear and the corticopontine fibers end in the region of the pons. So the corticopontine fibers go to the pontine nuclei. The corticonuclear fibers will end in the region of the facial, abducent nuclei, and then go on further and into the various tracts. So once you remove this transverse layer, you see longitudinal fibers again coming into the picture. And this is the MLF, the medial longitudinal fasciculus, the central tegmental tract. And this region, you will have the the trigeminal lemniscus and the spinal lemniscus. You see this pigmented area here, which we will see also on the floor of the fourth ventricle, and that is the region of the locus coeruleus, which it consists of some pigmented cells, and it comes in this trigeminal area. So here you again, you can see the three layers. So the first transverse layer, the stratum superficial, the longitudinal fibers of the corticospinal tract, and in the depth, the again transverse fibers, that is the stratum complexum. Now, when do you call it the pons and when do you call it the middle cerebellar peduncle? So the point of emergence of the fifth cranial nerve, that is the trigeminal nerve, you can see the small motor root, which is superiorly, and the large sensory root, which is inferiorly. So the part where it is lateral to the trigeminal nerve is the middle cerebellar peduncle, and this portion is the part of the pons. Here again, you can see this beautiful dissection done by my colleague, Dr. Sukhdeep, and here you can see how he has separated these fibers into the superficial layer, the longitudinal layers, and the deep layer. Now, once you remove the longitudinal tracts in this region, you will straight enter into the fourth ventricle. So these are the cerebellar nuclei, that is the globose and the emboliform nuclei that you will see into the roof of the fourth ventricle. Now, coming from laterally, so this is the lateral aspect of the pons. Here you see this is the flocculonodular loop. This is the trigeminal nerve. This is the facial nerve as it is arising from the pontomesencephalic sulcus. And this is again zone 1, or the region of the middle cerebellar peduncle, where it is relatively safe to enter into the pons. Again, coming from anteriorly or ventrally will be difficult because you have fibers of the corticospinal tract. So entering the pons is relatively easier when you're coming from the middle cerebellar peduncle. Now, when we see the fibers laterally, this is how it will look. So these are the first layer of the on the sagittal aspect of the pons. Here you see some fibers. These are actually fibers of the superior cerebellar peduncle as they are forming the roof of the fourth ventricle. This is the region of the fourth ventricle. Here you can see that this is longitudinal fibers of the corticospinal tract as they're going down and going to form the pyramid. Here you see one bundle of fibers that are closely coming on the posterior aspect, having a concave shape here, and coming here and lying right beneath or posterior to the corticospinal tract, and that is the medial lemniscus. That is the sensory pathway, which is also another very important pathway which decussates in the medulla. So these are fibers of the sixth cranial nerve as they're coming out and going into the pontomesencephalic sulcus. These are the regions. This is the region of the middle longitudinal fasciculus. This is again the fourth ventricle and the superior cerebellar peduncle. So again, this is another image to show the fibers more closely. This is the corticospinal tracts. This is the medial lemniscus. This is the MLF. And then this is just a picture to show how the fifth nerve traverses, comes from the nuclei here and comes out on the lateral aspect of the pons and comes out here, and you can see it. So when you're entering the pons, that peritrigeminal area is a very safe area to enter into the pons, which I will show you. So the pons extends from the pontomesencephalic sulcus to the pontomedullary sulcus. So in the region of the pontomedullary sulcus, there are cranial nerves which emerge. So the first one that you see here is the sixth cranial nerve, and here laterally you will see the seventh, eighth cranial nerve complex. And this area that we are very familiar with is actually the CP angle, the cerebellopontine angle, which we used exposed with the retrosigmoid trajectory. So this is a glioma that is involving pontine glioma involving the middle cerebellar peduncle and the ventral and the part of the pons. So again, the best trajectory for this is coming from laterally through zone 1 through the middle cerebellar peduncle, and you can remove this tumor. So when you are coming laterally, you should remember that the safest area to enter is below the trigeminal nerve and above the facial eighth nerve complex. So this peritrigeminal nerve area is a relative safe area to enter into the pons through the middle cerebellar peduncle. So when you expose it, you generally do it through a retrosigmoid trajectory. So you see that the cerebellum has been retracted. Here you see the fifth cranial nerve, the seventh, eighth cranial nerve complex, and the lower cranial nerves. So this is the region where you will be entering between the fifth and the seventh cranial nerves when you want to expose pontine tumors. So if you see this image, this is an operative image. Here you can see the fifth cranial nerve. You can see the seventh, eighth cranial nerves vaguely here. And you can see the diffuse bulge of the brainstem. And you can enter this in between these two nerve complexes or around the peritrigeminal nerve in this region. So as I said, the anatomical areas in a brainstem tumor will be a little bit distorted. So if you find a diffuse bulge and you find it is safe to enter, it is best to enter from that trajectory instead of looking for landmarks. A couple of interesting cases. So this is a very interesting tumor. So you see this is occupying the whole of the pons here. You see it is hyper on T2. And if you see it is going right up to the ventral aspect of the pons. Now, the best way to approach this tumor will be from the floor of the fourth ventricle. So as I will show you images of the floor of the fourth ventricle later, but this is through zone 2. So this is the suprafacial entry point and this is the infrafacial entry point, which I will show you later. But this tumor, we can enter from the floor of the fourth ventricle. Again, this is a cavernoma in the posterior aspect of the pons. Again, it is projecting into the fourth ventricle, and you can remove this tumor by going through the fourth ventricle and entering at the point where it is projecting the most. So as I showed you that case, this is again another interesting case. You can see this lesion occupying the whole extent of the pons, but projecting into the fourth ventricle. And this was actually an endodermal cyst. Retrospectively, we saw, you can see that there is a small communication with the ventral aspect of the clivus here. And here you can also see it in these images. So this turned out to be an endodermal cyst, an intraaxial endodermal cyst. This is again another tumor which turned out to be an intraaxial endodermal cyst. And we reported these two cases, but both of them were approached to the dorsal aspect of the pons. Again, another. Ahmed, am I out of time or can I continue?
No, we just lost your voice for a brief moment, then it came back.
Okay, thank you.
So you can continue.
Okay, so this is again another cavernoma in the dorsal aspect of the pons, which is projecting into the fourth ventricle. Again, approach through the fourth ventricle, find the projection and enter into the cavernoma. And this is the post-operative image. Again, another tumor in the pons, which was approached through the fourth ventricle. Here you can see the trajectory of the approach, and you can see we've removed the tumor completely. This is again a tumor that we've entered actually from the floor of the fourth ventricle, because you can see the bulge here. Now coming from here will be too much of a traverse of, white matter. So it is safest to come here because of this bulge and then remove this tumor. This turned out to be a high-grade glioma. I don't have the post-operative image, unfortunately. This is a cavernoma we did recently, again approached through the floor of the fourth ventricle. Here you can see the tractographic images showing this is the middle cerebellar peduncle, the corticospinal tracts displaced anteriorly, and you can see the trajectory of our approach through the floor of the fourth ventricle, and this is the post-operative image. So coming down to the medulla, now this is the last bit of the brainstem, which extends from the pontomedullary sulcus all the way here down to where the medulla becomes the spinal cord. Where is this level? It is at the level that lies just below the pyramidal decussation. So above the pyramidal decussation, you will call it the medulla. Below the pyramidal decussation, we'll call it the spinal cord. So the ventral aspect of the medulla has these two prominent tracts, and these are the corticospinal tracts or the pyramids as they come down from the pons and run into the spinal cord. Lateral to this is this gray matter mass, and that is the olive. Here you can see the various cranial nerves coming out. So the sixth cranial nerve, the seventh, eighth cranial nerve complex. We'll see these as we go down. So the cranial nerve, so the medulla has a median sulcus. It has an anterolateral sulcus and a posterolateral sulcus. So the olive lies here between the anterolateral and the posterolateral sulcus. The nerve roots that arise from the ventral aspects, so medial to the olive from the anterolateral sulcus, is the hypoglossal nerve rootlets, and the nerve rootlets that arise from the posterolateral sulcus are the rootlets of the glossopharyngeal and the vagus nerve, and they come out from this region. Next to the pyramid is this structure, that is the olive. Before you see the gray matter of the olive, you see that there are some transverse fibers that actually run from the pyramid all the way to the olive and go on to enter into the inferior cerebral peduncle. These are the external arcuate fibers that connect the arcuate nucleus from the mid aspect of the medulla to the inferior cerebral peduncle. So here you can see again, this is the pyramid. You can see part of it we have removed, and you can see the corticospinal tract now as they're running. This is the olive. This is the region of the inferior cerebral peduncle. And these are the rootlets of the glossopharyngeal and the vagus nerve. So now you can see this dissection. Part of the corticospinal tract has been cut, and you can see the fibers now more clearly. And here you can see how they are decussating, and this is the pyramidal decussation. So majority of these fibers, pyramidal decussation will go on into the lateral corticospinal tract. Some of the fibers continue straight down without decussation to form the anterior corticospinal tract. Here you can see again the rootlets of the hypoglossal. Here you can see the rootlets of the glossopharyngeal and the vagus nerve. So just above the pyramidal decussation, you have another decussation in the medulla, and that is the decussation of the medial lemniscus or the sensory decussation. The sensory decussation lies above the pyramidal decussation, and then it forms the medial lemniscus and goes all the way up to the thalamus. So again, this is just an image showing the corticospinal tract, and this is a close-up view of the decussation and all the corticospinal tracts as they're running here, and they're decussating and forming the pyramidal decussation. So that is the ventral aspect of the medulla. Now coming to this most important region that we expose surgically, and that is the floor of the fourth ventricle. So below this level, the medulla is closed, and above this level, the medulla actually opens like a book. And so the central cavity that is closed in the medulla actually opens and becomes the floor of the fourth ventricle. So it is very interesting to know that when you're coming from the spinal cord to the fourth ventricle, so you have the anterior horn cells and the posterior columns in the spinal cord. So when the cavity opens, the sensory nuclei become lateral and the motor nuclei remain central. So that is an important way to remember the organization of brainstem nuclei in the floor of the fourth ventricle. So the first layer here is the ependyma of the fourth ventricle. Once you remove this, so on this side, the ependyma is maintained. On this side, we have started doing the fiber dissection. Once you remove this, you will see the structures. So in the midline is the median sulcus that divides the brainstem into right and left half. The whole region of the fourth ventricle is also known as the rhomboid fossa. You can see its shape like this. And this rhomboid fossa can again be divided into three parts. So the superior part, so this is the superior triangle, the inferior part, and the intermediate part that you can see here. So the superior part, the boundaries are the superior cerebellar peduncles here, and inferiorly, it is the line that is going through the superior fovea above the facial fibers. So this is the superior part. It has the apex superiorly. Here is the inferior triangle where its apex is inferiorly. Again, it is bordered here by the infrafacial zone and by the inferior cerebellar peduncles. And the intermediate zone actually lies between the two fovea, the superior and inferior fovea, and the tinea that connects with the fourth ventricle. So this is the medial sulcus. There is another lateral sulcus. This is the sulcus limitans that divides the floor of the fourth ventricle into two parts. The sulcus limitans, this region, deepens in the superior and inferior aspect. In the superior aspect, this is known as the superior fovea. In the inferior aspect, this is known as the inferior fovea. So let's look at these fibers. So right in the midline, you will have the MLF or the medial longitudinal fasciculus. Just lateral to it, you will have the central tegmental tract. The most prominent region in this floor of the fourth ventricle is this facial colliculus. The facial colliculus is not the facial nucleus. It is actually the abducent nucleus, and parts of the facial nerve fibers, as they are originating here from the facial nucleus, going and turning medially and then coming out to an exit from the pontomesencephalic junction. So this is the region of the facial folliculus. See how close it is to the MLF. So when you injure the brainstem in this region, you always have deficits that involve the facial nerve or the facial you have facial deficits or you have eye movement deficits, and because you damage the MLF, you will also have gaze paresis. So this is the facial colliculus. Here you will see there are fibers of the trigeminal lemnisci that are going up, and this pigmented region that you see here is the region of the locus ceruleus. So then you see these fibers that you also see on the floor of the fourth ventricle very nicely. These are the striae medullaris, and they originate from the cochlear nuclei, which here lie laterally, and they enter into the midline, into the median sulcus. Inferiorly, you have the hypoglossal triangle, and this part, medial part, consists of the hypoglossal nucleus. The lateral part consists of the nucleus intercalatus. Laterally, you will have the vagal trigone, which has the dorsal nucleus of the vagus and the nucleus ambiguous. And all these areas culminate here in this region. As you can see, it is called the calamus cryptarius. It has a shape of a pen nib, and it enters into the is region of the obex, and it enters to form the central canal. So again, this is a close-up view of all the fibers that you can see now. So you can see the facial colliculus in this region. You can see the MLF, the central tegmental tract, the trigeminal lemnisci. And this is a cut section of the medulla where you can see the various structures. So this is the pyramids. The medial lemniscus, after its decussation, lies right here in just posterior to the pyramids. This is the vestibular area. This is the inferior cerebellar peduncle, and this is the region of the fourth ventricle. So for medullary tumors, there are very limited avenues. If it is ventral, you can either enter from the anterior or the posterior lateral sulci. And if it is dorsal, in the region of the inferior cerebellar peduncle, you can come from midline through the floor of the fourth ventricle. So this tumor we approach through the midline, through the floor of the fourth ventricle. And this is the approach, again, a midline suboccipital craniotomy, but coming here, not going superiorly, elevating the tonsils, seeing this inferior medullary velum and entering into the fourth ventricle. You can see the bulge of the tumor and then remove it. Similarly, this is on the lateral aspect of the medulla, which you can enter by using this retrosigmoid trajectory and extending it down to include a part of the C1 and the C2, and then approach the tumor in this region. Of course, you have to work between the cranial nerves, which might be a little dangerous. So these are the safe entry zones to enter into the ventral aspect of the medulla. So the anterolateral sulcus and the posterolateral sulcus. But of course, you have to work between the cranial nerves. So it is best to go in from where the bulge is coming out. So this is all about the brainstem and its safe surgical corridors. I thank you very much and be happy to answer any questions.
Thank you very much, Professor Abeda. Very fantastic presentation and very nice explanation of the safe entry zones of brainstem. We make it look easy, but we all know that it's very demanding technically and need someone to be very aware of the anatomy and of the fibers and the nuclei of the brainstem and have very good technical skills to do the things that you do. So thank you very much for this presentation. And if anyone of the audience have any remark or any questions, please, you can ask directly or ask in the chat. So Dr. Abeda, in brainstem gliomas or tumors, do you usually always do tactography for these cases or no?
We don't do for all, but yes, sometimes when we want to study. See, if you know, I'll tell you one thing, Ahmed. If you are doing it initially, you should do tractography. But once you have a way of the anatomy, you tend to know where the fibers are displaced. Then you don't need it. But tractography always helps. It is not a bad thing to have the tractography in your armamentarium. It is a good thing to do. But don't rely on
Okay.
the tractography. Go on your knowledge of anatomy to see where it is, to understand where it is displaced. Because sometimes the radiologist will just give you some superimposed images and you will be lost. You will not understand where you are. So you should know the anatomy to complement that radiology.
So it be supplementary to your knowledge in anatomy, not to be rely on it
Yes,
entirely.
yes,
Yes.
yes. Yes.
So Dr. Atul, I think he couldn't join us.
Yeah.
As you said, he's traveling. Where Dr. Hazem Abbas said, thank you for nice and knowledgeable lectures. Yeah. And I think we don't have any questions here.
Okay.
See, let's check this. Okay. Uh, Dr. Sudhir Singh asks, does intraoperative monitoring help?
Yes, intraoperative monitoring can help during brainstem tumor surgery because at least you will identify the areas, you'll be able to identify the nuclei where you are not supposed to enter. So it can help.
Okay. I don't see any further questions. Okay, we have Dr. Ayman Abu Bakr asking about, do we have to change our discussion according to layers or just one section? do we have to change our dissection according to layers or just one dissection?
So
I think
you would
during
not be able, understood. You will not be able to identify the layers when there is a brainstem lesion or a brainstem tumor. You will just see some white matter. So as I said before, try to enter as laterally as possible if you can get a safe point. Otherwise, go in the most prominent part of the tumor where you know you will, with minimal damage, you would enter into the tumor. So that is where you should go, keeping in mind the safe entry zones. So if you're on the floor of the fourth ventricle, you know that the facial colliculus is here. Even though there is a bulge, try to enter from little above or below it so that you don't damage that area.
Okay. We don't see any more questions. So thank you very much, Professor Obeda, for this fantastic presentation.
Thank you,
And
Ahmed.
we are grateful for your continuous support to our webinars, and we hope to see more of your presentations and share more of your knowledge with us in future presentation, inshallah. Thank
Thank
you
you.
very much, Doctor.
Thank you. Thank you.
So with this, we can conclude our 15th webinar, and we see you all, inshallah, next week with more presentations, inshallah. Thank you, everyone, and see you next week, inshallah.